So cancer as a process requires a number of things to happen before it can do the things we don't want it to do to the human body. First of all, there's got to be unchecked cell multiplication. Normally our body's pretty organised, and cells only divide when they're meant to, and when they're not meant to, the process is shut down. So that's one of the fundamental things that cancer is a process where the cells keep dividing when they should stop. Secondly, they can then get out and about and invade into the local tissues, and if they can migrate through blood vessels and other channels called lymph channels, then they can set sail around the rest of their body. Now, when and if a cancer cell or cluster of cells gets to another part of the human body, it's then got to invade into that part, or if it doesn't find a home, it dies, and of course that's what we'd like to happen. If they can invade that cluster of cells, they can establish their new blood supply at the new site, and that site is called a secondary site. So the place where the cancer starts is the primary site, and the outposts are called secondary sites. And again, in the secondary site, the cells can then divide and multiply and impact upon the function of where else in the body they've landed. Along the way, the cancer cells, either at the primary site or secondary sites, must evade the body's immune system. The immune system is lurking, but unfortunately one of the hallmarks of cancer is that it's able to trick the immune system into ignoring it and letting it go about its business. And more of that later, because there's some exciting developments. This whole process can be summarised in a picture, which shows the primary site, and we'll have a go. There we are. There's the primary site, invasion into blood vessels, migration around the body, and the establishment of an outpost or a metastasis somewhere else in the body. And for those with keen eyesight, there are little mentions of genes at every step, and the genes are very, very important to the fundamental process of cancer. And as you can see, we clever scientists have identified a lot of the important genes that are involved in these processes that cancer acquires. So cancer, it's in the genes. I think this is where we get to probably the most complicated bit of my overview, but stay with me. Because it's important, because there's a lot of important stuff tucked in here, and particularly with regard to new treatments that are coming down the pike. So every cell in the human body, and we'll have a look at a cell. So our body's made up of billions of building blocks called cells, and within the cell there's an important structure called the nucleus, and within the nucleus are the chromosomes, and that's all our genetic material. So in every cell in our body, there's this precious genetic material, and of course, at a finer level, we call this genetic material DNA. And the DNA is a special code. It's the blueprint for life, and most of the genes are well behaved, and they tell each of our cells in our body what to do, how to behave, how to look, how to function. But within every cell there are these oncogenes. So there are these tumour promoting and suppressing genes called oncogenes. Now normally these are tucked away quietly, minding their own business. Some of these genes have important functions in normal cells, because in health we need our cells to be able to divide so we can repair defects in our skin, or if we get a cut. So these genes have got to be activated. But normally when they do the business and the healing process is completed, the genes are shut down and they go back away, lurking in the shadows, as it were. But if there's a mutation, that is, a bit of a gene is moved to another place, or there's some error in the blueprint, the oncogenes can come back out of the closet, as it were, and misbehave. and that can switch the cell on to divide and multiply in an uncontrolled manner, because it's not meant to happen. But if the gene's activated, then often the cells start to misbehave and can be the first stage of a cancer. We do know, though, for most of the common cancers, and GI cancers are included here, that usually it requires multiple genes to be activated, and a cancer is an evolutionary process, which I'll show on a couple of slides down the track. Every now and again, in a particular cancer, there's a dominant or driver mutation. But for the most common cancers, GI cancers, it's usually a number of genes misbehaving that causes the process. So that slide is illustrative of the development of bowel cancer from both an appearance point of view and also a genetic point of view. Starting out with the normal lining of the bowel, with certain mutations, a benign process called an adenoma, or often referred to as a polyp, can develop. And if no other mutations occur, that just stays as a benign structure, totally harmless. But if further genetic changes occur down the pike, they can become bigger, and then this process usually takes years to happen. And then finally, if the cells acquire other mutations that can turn it into a cancer, then the process is often running. So we more clearly understand which are the key genes that are driving the process, and as time goes by, the cancer acquires more mutations. So in terms of what causes these mutations, what causes these genes to come back out of the closet? Well, some of us, a small number of us, thank goodness, have inherited mutations that run through the family. So we've all heard of the BRCA genes, that gene family, which increase the risk of breast and ovarian cancer. And there are some well-known genes, the MSI, microsatellite instability. We can't think up simple names. And the familial adenomatous polyposis gene, FAP gene, which in a small number of families underpin their higher risk of bowel cancer. So some of us start life with an inherited tendency. The second important factors that can cause cancer are the internal body environment, so without us doing anything to ourselves. The hormonal environment is pivotal in certain types of cancer, and the immune system is important in terms of surveillance, and if our immune system isn't competent, we're at more risk of getting certain types of cancers. But the big ones that we can focus on, because we can potentially modify them, are the environmental factors. So UV radiation usually from the sun, chemicals, whether we apply them or ingest them into our system. The commonest chemical, the commonest toxin we ingest is alcohol. We can inhale carcinogens through cigarette smoke, dust, asbestos. The other environmental factor, which is most relevant tonight, is to what we swallow, what we eat. So the chemicals and other byproducts of our food. And finally, viruses can be an important environmental factor. So what can we do about that? Well, we can't change our parents. My kids would like to occasionally, particularly after Saturday night in here up on the dance floor, but anyway. But for people who are members of a family who have a known germline mutation, they can undergo more vigorous and early screening. So they can do something about picking up a potential cancer earlier. But for most of us, the essence of minimising the risk of cancer is to minimise our exposure to carcinogens, which is what the whole mob are called, and adopt a lifestyle which is known to be associated with a lower risk of cancer. And the public health officials sum it up in the acronym SNAPS, which stands for smoking, nutrition, alcohol, physical activity and safe sex. So in terms of what can we all do to lessen the risk of GI cancer, we can eat eat more healthily, eat more fruit and vegetables, we can exercise more, and we can reduce our intake of alcohol, fast food and cigarettes. It's not rocket science. It's estimated that 30% of cancers could be preventable through a healthier lifestyle. 3 in 5 Australian adults are overweight or obese, and 90% of us aren't eating enough fruit and vegetables. So there's a lot of scope at a population level for reducing our risk of getting cancer. Moving on to prevention, to quickly talk about screening. Clearly, if we can detect cancers, or even if we can detect polyps, as an example, at an earlier stage, then it's more likely that the treatment will be successful and have a good chance of cure. Good research has developed some screening tests, and the one of most relevance to this presentation is the detection of small, barely, well, you can't see it, invisible traces of blood in the bowel motions. And so because of research, our government has, or as a community, we've decided that we will offer people routine screening for the detection of early bowel cancers. So we know that some polyps and some early bowel cancers have fragile blood vessels on their surface, and we can lose small microscopic amounts of blood into the stool, which can be detected by these very, very sensitive tests. Sounds a bit gross, and the next slide doesn't require any great explanation. Sounds a bit gross to be fiddling with one's own bowel motions, but it's well worth the effort. And many people in our community have had bowel cancers or precancerous lesions detected at a much earlier stage. So that's screening. Then moving along, we get more into my backyard, which is down in the oncology clinic. So the key things oncologists and other specialists involved in the care of people with cancer must do is, first of all, name the cancer, and we can only name it if we get a piece of tissue. There are different types of cancer, and they behave differently and require different treatment approaches. So we have a saying in oncology that tissue is the issue, so we need tissue to be sent to a pathologist who can look at the cancer under the microscope and tell us what type it is and what other characteristics can they tell us about it. The second thing is to stage the cancer, and I'll talk more about this in a minute. Once we've got this information, a treatment plan can be developed. And the way we develop treatment plans in 2016 is usually working in teams of specialists where we all bring our skills and experience to bear. The person is presented, their situation is presented fairly anonymously, and we look at the pathology, we look at the staging investigations, and we give the referring doctor a suite of recommendations to take back to the person to say, well, this is what the meeting of the team suggested would be a reasonable treatment plan for you. It doesn't bind any party to that recommendation, but it's an incredibly valuable process, because having other minds at work who are one step back from the person can lead to very, very useful suggestions. And reviewing the pathology and reviewing the x-rays can often unearth other things that can be a bit of a surprise that might make a major change to a person's treatment and outcome. So just quickly stepping through these, giving some illustrations. So under the microscope, we've got two different types of cancer that can affect the bowel. The one on the left is a sort of fairly common type of cancer of the bowel, and on x-rays and looking into the bowel, they can look exactly the same as a quite different type called a neuroendocrine tumour. Less common, but markedly different in its behaviour and the treatments. So we really need to know what type of cancer we're dealing with so that we can devise the treatment that's appropriate. Staging of the cancer is, whoops, we've got a bit of musical background. Basically, staging is working out how far has it gone. So Within the primary area, there can be 3 early stages, 1, 2 and 3, or A, B and C. And that really, this is an illustration of staging of bowel cancer. It's probably a bit hard to see from the back of the room, but it's all about how far through the wall of the bowel has it gone, and has it spread through lymph channels to lymph glands in the neighbourhood. And stage 4 usually signifies that it's found in other organs of the body. So why would we bother staging a cancer? The stage is clearly related to the chances of the outcome. So this, when we oncologists consider groups of people, clearly one of the key things we're interested in and our patients are interested in is what are the chances of cure, what are the chances of survival. So this slide illustrates it could be any cancer, it doesn't matter which one really. But for each stage, there's what we call a survival curve. So you'll be able to see that for a stage 1 cancer, nearly 100% of people are alive, say 60 months or 5 years down the track. And as we step through the stages, the number of people surviving is less. So this provides people with very useful prognostic information so that they can plan their lives, so that they can know whether a particular treatment is worth it or not. So that's very, very useful information for the person and their advisors. Clearly, what we're trying to do through research is get more people in the early stages through screening and early diagnosis, because if you're starting out on one of the higher curves, then life's prospect is a lot rosier. But also, as well as trying to shift the numbers of people up the curves, we're trying to shift the curves up through different treatments. So we're trying to improve the outcome for every stage through research, and Louise will mention some of the ways that the Gastrointestinal Institute or the AGITG is trying to achieve that. Okay, so we get to treatment. So we've named it, we've staged it. Okay, what treatments have we got? Well, as many of you will be aware, there's a wide range of treatments available through surgery, radiation therapy, systemic therapy or drug treatments. Also, we should mention interventional radiology. Some of our X-ray specialists have wizard skills at being able to put catheters into various parts of a person's body and give treatments directly into that part of the body. And also, just as important is the focus on symptom control and supportive and psychosocial care. So there's research and advances going in on all those fronts. And in very small print at the bottom of the slide, what are we trying to achieve? Well, we're trying to get the best result for people, whether it's cure, longer survival, relief of symptoms, with the least impact on their body and mind. And I think that we can't forget the mind. Just briefly, some advances in the treatment of GI cancers in the surgical field. I guess the keyhole surgery, laparoscopic surgery. I often say to people that some of these people are so clever they could renovate your house through your front keyhole. So that's a big advance, because people can have surgery that they can be out of hospital quicker, less troubles with wounds healing and so on, and just as good outcomes in certain circumstances. Our radiotherapy colleagues are leaping ahead with better radiotherapy planning techniques, and also the whiz-bang machines that can deliver more specifically the radiotherapy just to the area we want, with less impact on the surrounding tissues. And that's the advances in my practicing lifetime have just been dramatic in radiotherapy. Then the drug therapies, we've got a range of new drug agents coming down the pike, and particularly those that are more accurately targeting particular vulnerabilities in the cancers. So we know about the genes and the mutations in some sorts of cancers, and we now have agents that can switch off those genes. And I'll briefly talk about that in a minute. And then in the issue of supportive care, there's been research, and a lot of it's been driven in Australia, looking at what better ways can we support people after they've finished their treatment. If they're fortunate enough to finish a package of treatment, in terms of their follow-up strategies and providing better support and information, and the impact that can have on a person's psychological well-being going forward. But all of these improvements have been driven by high-quality ethical research, and Australia is one of the leaders in that research. Pound for pound, we bat well above our weight. Now, you can't have a talk from my sort of drug oncologist without talking about targeted therapies. For us, they're the way of, they're here now, and they're clearly the way of the future. Just to give you an illustration, looking at that pathway from the back of the room, you might think, crikeys, that looks complex, there's squiggles and names going everywhere and there's little nodes. Well, on closer inspection, that's the London Underground. And we know that even though it looks complex, and it probably is, even though we know it looks complex, once people understand all the links and so on and the timetables, it's actually understandable. And that is, I wouldn't be so arrogant as to say we understand the human body as well as we do the London Underground, although people who've travelled in London might argue the toss that nobody understands the Underground. We can look in the human cell and we can understand some of the pathways and linkages. And this is an illustration of but one cellular system that sort of starts at the surface of the cell. So that's the surface of the cell, and we've got the nucleus in here with the genes. I'm sorry if you hear people over there. I can't point in two places at once. You need a radiation oncologist, they'd be able to. And normal chemicals come in and activate what's called a receptor on the cell surface, and that receptor then communicates into the cell where it's got a little tail sitting in the cell, and that triggers a cascade of chemical reactions and so on. And a lot of them end up in the genes, telling the genes what to do. So this is normally a very regulated process. You know, our body's got a yin and a yang for everything in the body. But in cancer, some of these cellular processes can be overactivated. They're switched on and they don't switch off. And most of them are driven by mutations within the genes. So the genes send out messages to say, right, activate this or activate that, and away we go. So we've been able to develop targeted therapies that get inside the cell and switch off some of these processes. Just briefly, one group of targeted therapies are what we call small molecules, and they get right in the cancer cell, and they're trying to switch off these chemical pathways to quieten the cell down. Now, of course, the challenge, as you'll remember from the previous slide, there's multiple chemical pathways. So often the cancer will sneakily work around the block that we've put in place, but it's a step forward. Sometimes in the setting when there's a single driver mutation, and that cell's relatively simple, and the examples I've got there are CML or chronic myeloid leukemia, or GIST, which is a rare form of gastrointestinal stromal tumour, have a single driver mutation that is switched off like magic with a targeted therapy. This has led to a variety of side effects because these drugs aren't like the standard chemotherapies that we've been using for 30 or 40, 50 years. They've got more specific and different side effects which cause us headaches. But by and large, compared to chemotherapy, a lot of them are much, much better tolerated. The human body generally tolerates them very, very much better. The upside, though, is we see some spectacular responses. Some of these that have got a driver mutation, the cancer just melts before our eyes. And in some types of cancers that we really hadn't seen that sort of thing before. The other form of targeted therapy that really is very exciting is immune molecules. So our immune system makes all these molecules that are trying to fight off foreign things in our body. The clever scientists have actually made the identical immune molecules in the laboratory that can target things on the outside of cancer cells. So I'm sure it's probably a bit hard to read from the back of the room, but there's an increasing number of cancers that have got a particular target, and these are the range of cancers. So of relevance to tonight, there's EGFR in colon cancer and VEGF in colon cancer that can be targeted by one of these antibodies that are usually given by injection at regular intervals. And by latching onto the outside of the cancer cell, it often quietens the cancer cell down. It sort of blocks the processes. But the other really crafty thing these immune molecules do is they've got a little tail on them. That's what you call the tail region. And so when the antibody or immune molecule latches onto the cancer cell, the tail's sort of sitting up in the breeze, and the tail attracts the other immune cells into the neighbourhood. Because the cancer's busily trying to tell the immune system to go away. Well, these antibodies say, hey, come over here, something going on here, and the immune system becomes much more interested in the cancer cell, interested in a positive way, in that they can set about destroying the cancer cells. So, but I've got to tell you about what we think is one of the most exciting developments in our specialty of medical oncology, are these immune molecules that are on the bottom of the slide. And what these do is tell the immune system to ignore the cancer cell in trying to tell the immune system to go away. So you've got a cluster of cancer cells. They're sending chemical messages to the immune cells that are sniffing around to say, nothing to see here, move along, go about your business. We've got now these monoclonal antibodies or immune molecules, and they're in our clinic now for some types of cancer, that can actually block this cross-chat. And so all of a sudden the immune system is activated right in the neighbourhood of the cancer. And so particularly in people with melanoma, but it's now extending to lung cancer, head and neck cancer, some subtypes of bowel cancer, we're seeing some quite dramatic tumour shrinkages with these new immune molecules. And so they're immune molecules that are working on part of the immune system, go figure. But it's one of the most exciting things that I've seen in my career. So the end result of all this, where we're working towards, is to take a population of people that look the same, their cancer looks the same under the microscope, but there's some quite fundamental biological difference, and we're trying to better separate them into biologically similar groups and treat those groups with the most appropriate treatment for their type of cancer. And I've got some examples there of the immune therapies, the anti-EGFR antibodies for a particular group, BRAF inhibitors for another group, and this is the way forward. But we'll only continue to make these advances by doing good clinical research, and this is where our community and our patients come to the fore by helping us all to answer the big questions. I think we owe it to our community to get this right. Cancer care is too important to sort of go off half-cocked on a warm feeling, and most, if not all, of the important advances that we've made to date in cancer care, and I say that in the broadest sense, have come through good ethical research. So we've covered a fair bit of territory in this brief talk, hopefully brief enough. So we've looked at the downstream bit where people like me come into play, but we've also looked upstream to the notion of screening and prevention, and we can't ignore any part of this spectrum. So I think that'll do for me. Thank you.